Okay, so my second topic, as I have announced, this will be talk about lung recruitment, PEEP setting in titration in ARDS using pressure volume curve, and not to be too, we will go into theory of course and the studies, but I would like to present this to you to a real case scenario that was in my ICU a few months ago. And also just to congratulate also my colleague for the previous lecture, which was great. And remember, he also showed you in the studies esophageal pressure, and this comes back to my first lecture, the more you are away from the optimal PEEP in plus and in minus, the less effective your mechanical ventilation will be. This is why this is important to set your mechanical ventilation. First step, optimize the PEEP, whatever. You will see I also use esophageal pressure, as does the colleague. So, to my case presentation, we have a 48-year-old female with a prior medical history of only mild arterial hypertension, so the woman is healthy. She had suspected gynecological malignancy. She did a cervical biopsy, waiting for pathological diagnosis, and it was a minimal 10-minute surgery under a light sedation, light general anesthesia. So 7 days post-surgery, she develops a sudden onset of dyspnea, and they give her oxygen, nasal cannula 4 liters, SpO2 is 96, respiratory rate 22, so at that date she's okay. But day 7, she has a sudden drop in SpO2 with 6 liters per minute, respiratory rate of 30, she's agitated, restless, lung ultrasound, I did a lung ultrasound, so they called me to evaluate the patient, minimal pleural effusion, and a lot of B-lines. So if we again look at the lecture on ARDS and the definition of ARDS, I would say that this concurs to the definition of ARDS. And we decided to admit her to the ICU. And per our protocol, we gave her high flow therapy, always max flow. Why? Because if you use the potential of high flow, first of all, this is what gives you theoretically the PEEP effect. And B, the problem with 30 liters in the guidelines is that in order to qualitatively assess for the FiO2, the flow on high flow has to be over your patient's peak inspiratory flow. And in severe distress and ARDS, the patients, remember the COVID patients, so they come to the ICU with a very high, we're breathing very high. This means a high inspiratory flow. So if your flow of your patient is over high flow, this means your FiO2 will drop and you can no longer take this as relevant FiO2. This means you have to have a flow that is over your patient's peak inspiratory flow. I will just tell you the 30 is for normal patients. In ARDS, it's usually 50 to 60, can go up to 100. This is why any machine you have, I always use the max flow, and then of course we never go with the FiO2 over 50%, but that's just our UC protocol. We don't want to miss patients developing SILE. I will show this later. So after 4 hours, unfortunately, yes, she has a relatively SATs and the saturation, but she was getting more and more restless, and then the SATs dropped, and then the respiratory rate increased, and eventually we had to intubate and invasively ventilate her. We decided not to do non-invasive because she was really agitated and restless. We could not cooperate with her. And this is the CT scan. Let me just see if I can. So please look at the video. See here, the whole of the lung. Only here you have this classic ARDS anterior-posterior different, but the whole of the lung is inflamed. And the diagnosis is pulmonary lymphangiatic carcinomatosis. So theoretically, this is then an extreme severe ARDS-like condition. So you block the lymphatic drainage, then you have hypoxic failure, which is an ARDS condition with a very high mortality rate. So by definition, this is ARDS. Oncologist then comes and says, oh, no chemo until I have a pathophysiological diagnosis. So you can either let this woman die, or we can try and help her bridge this time until she at least gets a little chemo that's going to work just to unload this situation. So clinical decision, of course, we will try and stabilize the patient until this pathophysiologic diagnosis arrives. Expected was 5 to 7 days max. So after intubation, we of course, as I've told you, we always do Intelivent, and as I have told you, remember when I intubate, I give minute ventilation for automatic, and PEEP, since I knew it was severe ARDS, let's say I just set it to 17. But look at here, I have a SATs of 91, and my FiO2 is 100. okay? And my minute ventilation percentage is 155 for 47 CO2, which is acceptable, let's say, in ARDS. So what do we do with this? What do we do with this? Are you satisfied with this? Well, I wouldn't be, of course. So remember my key components. This is number one. So first I have to set this up. Then I will think about all these things later. And then of course the question is, I already gave in 17 of PEEP, right? Remember? And nothing happened. So my question is now, do I do or don't I do lung recruitment? By definition, lung recruitment is the use of transient increase in transpulmonary pressure to reopen previously collapsed and non-coagulated lung units. Okay, so this is it. And we know that there is a lot of potential, and these are three key components I will point to you now. First of all, this is your classic ARDS lung. So all of us who have shown you slides, here you see mild overdistension, then you have open alveoli, then you have cyclic opening and closing, right? And these are closed. So this is classic ARDS. The problem is three Y's. First of all, oxygenation. Here is practically the baby lung. Here is dead space ventilation, right, with overdistension and stress to the alveoli. So we cannot give normal tidal volume inside, and we will have problems with oxygenation, right? Okay. The second problem is, if you look at it here carefully, you have here in overdistended alveoli, you have dead space and increased pulmonary vascular resistance, right? Okay. But also here in the collapsed alveoli, you have increased pulmonary vascular resistance again. This is something I would like you just to remember, because we'll come to this later. And of course, we have areas of lung homogeneity that will risk us our ventilator-induced lung injury by cyclic opening and closing. So the idea of theoretically lung recruitment is to optimize the lung and homogenize as much as possible in order to stabilize pulmonary vascular resistance, stabilize oxygenation, stabilize ventilation, etc., remove the risk of Wiley. But there is also one key point nobody's talking about. You know what's the problem with this lung? Let me tell you, we were talking about tidal volume, we were talking about driving pressure, we were talking about transpulmonary pressure, about plateau pressure in the PEEP. So my question for you is, okay, you trust in all these measurements, right? Compliance, resistance. But what are you measuring in this lung? The problem for you is, are you measuring compliance here, 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 or here? Because I tell you, it's like 500 different compliances. And the problem for our mechanical ventilation is that what we measure is one point in time as a joint sum of all these different compliances, regardless of whether, as in Hamilton ASU, intelligent ASU, you use Hamilton, then you have a proximal flow sensor which is right next to the tube, or as in other ventilators you have it in the machine. Then of course keep in mind, the problem is that also you have the tubes. And theoretically, if you use original tubes from the manufacturer that have input original measured compliance, then okay. But if you use supplemental tubes which are cheaper, then you have absolutely, the machine has absolutely no idea of the compliance of the tubes. And what you're measuring applies to what part of the lung, please tell me. I measure one joint sum, does it apply to this one? No. To this one, no. Maybe to this one. And that is the problem. But if I can homogenize the lung by a successful lung recruitment maneuver, then beside all these benefits that I have, I will also have a homogenized lung, and then what I measure and want to apply to my patient applies to the most of the lung, okay? Meaning I will make less injury in terms of cyclic opening and closing, in terms of overdistension, but also I will have less collapsed units. Of course, that sounds great, right? So if I tell you only this, everybody wants to do lung recruitment. And the problem is that there's a very lot of number of potential risks of lung recruitment maneuvers. First of all, in the open alveoli, we can make worsening alveolar distension, worsening the dead space, and of course, if we worsen this, we have increased pulmonary vascular resistance. Remember, we'll get to this later. Worsening lung homogeneity. If you apply pressure to lung like this one that cannot be opened, then nothing will come here. You will just over-distend this one to extreme, but also over-distend the ones that were previously normally open. And of course, if you don't apply the correct PEEP, maybe you will transitionally open the lung, but then you will just have an increased number of these inhomogeneous alveoli that will eventually close back, but during the time they're open, you will have cyclic opening and closing. And you have seen in the lecture what it does to the alveoli. So now, do you or don't you do lung recruitment maneuvers? So how many of you still do lung recruitment? Nobody else? 2, oh, thank you. 3, oh, thank you. So the problem is, and this is why, if you look at the studies and you go to a congress, the biggest fights, right, PEEP and lung recruitment. And usually you have 2 professors and it looks like this. So this is the classic congress in mechanical ventilation in ARDS. So let's look at some, and they say, no, we put you the guidelines and then you do it like that. Yeah, we'll see. The problem is that yes, there are studies that are in favor of lung recruitment, and this is undeniable. If you look at a study, for example, by Kaczmarek, they took PEEP effort to table, converted it to a lung recruitment decremental PEEP trial, and you can see that there is an increase in PA2 to effort to. A decrease in driving pressure means a homogenization of the lung. If you have inhomogeneity, you will have a reduction in driving pressure. But if you homogenize, that means you open, more lung is open, less is over-distended, less is closed. You have less pressure for the same tidal volume. This means a decrease in driving pressure, right? Okay. And of course, if you look at the systematic review done by the Toronto group by Ivan Golliger, and in 2017, you will see that there is systematic review from the older studies showing better oxygenation, theoretically even lower mortality or less fluids for rescue therapies in favor of lung recruitment maneuvers, okay? This is lung recruitment, this is lung recruitment, this is lung recruitment. But then comes 2017, and there comes the ARDS trial, okay? And then after the ARDS trial, everybody stops using lung recruitment. So please, now raise your hands, how many of you have read the complete ARDS trial? So the whole study. The whole study that took you one of the best weapons to optimize lung volume out of your hands, because later you will see it was copied into the guidelines. So none of you read this study, and yet you allow the guidelines to take one of these best weapons out of your hands to optimize your patient's condition in ARDS. So let me show you what you allow them to do. You allow this study, and you have seen the results in the previous, I know in the first lecture. Yes, this group with lung recruitment had increased mortality, but very nice. First of all, let's look at some evidence-based data. They really like this term evidence-based. I don't. Let's see why. Is this evidence-based if 2/3 of the patients were in septic shock and only 40% in the lung recruitment group had this lung recruitment maneuver completed? Of course not. If I cannot complete lung recruitment, how can you evaluate this? Now the problem is, yes, they had increased mortality, but do you know how they did the lung recruitment? They did it using the staircase maneuver. Anybody of you know how staircase maneuver works? Okay, so you increase pressure with a constant driving, and then you get to a certain PEEP. So what they did, they go up to 45 of PEEP, 60 centimeters of water of the upper pressure, and keep your patient there for 1-2 minutes. And then when patient starts dying, they amend the protocol to 35-50. Now please raise your hands, how many of you would ever in your life apply 35 or 45 of PEEP and 60 of the upper pressure for lung recruitment? Of course not. Because the only thing that can happen to your patient is he's gonna die. And this is why I call this maneuver staircase to heaven. Because this is the only way your patient is going, and that's up there. So why take this? So, and on question B, would any one of you, So let's say here you have your professors, your leading of your societies. Would you, in your ethical component, sign off this study be performed in your ICU? Would you do it? Would you allow people, they say come to you and say, please, we want to also your ICU included, you have to do lung recruitment 45, 60. Would you do it in your ICU? Of course not. So why, if none of us would do it, and I never found one person, and I teach this for years, and nobody said I will do it like that. Because we know it's not normal. I cannot say any other expression for this. It's not normal to do it. It's unphysiological, it's too aggressive. So why take this, something that we would never do as lung recruitment, as a way to say we don't do no lung recruitment maneuvers? And this is our problem. Even if we read the guidelines, and then we take a paper, and maybe we just read the abstracts. But nobody truly reads the papers. And this then, of course, is not evidence-based medicine for me. The only thing it shows how not to do it. So don't do it like this. I told you why. Okay. And then, of course, there's all sorts of systematic reviews, like the one published in 2022 by this you have seen this slide, I think, in the first lecture, if I remember correctly, that probably there is beneficial from lung recruitment, just not from the prolonged ones. Of course not. If you sustain too much pressure for too long period of time, no hemodynamic is going to take it out, and of course your patient is going to arrest, and then your norepinephrine, and of course the alveoli are going to burst. But it doesn't mean that we should not apply maybe another technique, and I will show you where the problem was in the uptrial. And now, okay, everybody likes American medicine. American medicine says, we have the guidelines. Because when we have the guidelines, we are safe from lawsuits. But we don't care about patients, do we, right? Because if the patient is lucky enough, you know what Gaussian curve is? So Gaussian curve, normal distribution, right? Okay, so if your patient is in the middle of the Gaussian curve, yes, maybe he confers to the guidelines and maybe he will survive. But he is off, he has absolutely no chance of survival. Because then you exclude our right minds, our clinical perspective, our measurements, and we just do the guidelines. And hope that he's in the middle of the Gaussian curve, which make him survive. If he doesn't, well, we did everything according to guidelines anyhow. And the guidelines say, you have seen this, recommend against prolonged maneuvers. But prolonged maneuvers are at least 1 minute. There is a nice study, I will show you later, that shows that this is absolutely 4 to 6 times too much time to do a lung recruitment maneuver. And I will show you later why. But they say, no, strong level against. Okay. Then again, there's brief lung recruitment maneuvers. I know this is too long. But they say, we suggest again against weak recommendation, high level of evidence of no effect. And then there's the expert opinion. You know how guidelines work? They give you guidelines, and then the expert who wrote guidelines has to give his expert opinion on this. And he says, like this, existing data do not support use of brief lung recruitment maneuvers, likely because lung mechanic events for brief raise pressure are transient, unless accompanied by other maneuvers. This means, of course, if I recruit the lung and don't optimize the PEEP and go back to 5 or 4, the lung is going to collapse. But this is exactly the reason why I do lung recruitment and then later optimize the PEEP. So how many you do lung recruitment and don't optimize the PEEP? There's no point, of course. So this is total rubbish, because we always have to optimize the PEEP afterwards. And then I say, nevertheless, they may have a limited role in attempt to reverse hypoxemia, blah, 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 and yet they recommend against. And you know what they're based this on? Take one quick guess, the ARDS trial. So it goes back to my question, why take a point that's a study nobody in their right mind would ever apply to the patients in their own ICU as a cornerstone to make guidelines on how or to do or not to do lung recruitment maneuvers. And absolutely has nothing to do with brief lung recruitment maneuvers. So even if it talks against something, it talks against prolonged ones. Okay, so my question is, why don't we just individualize the patient? You know, if I wanted guidelines, then I can make a chimp do the ICU. then you don't need a doctor on an RT, if I'm going to be at the bedside. So we know, and this is uncontested, that there are patients who respond to recruitment in ARDS, and then there are those who don't. And we call them recruiters and non-recruiters, okay? And then, and this is most important thing, first of all, the ARDS trial never assessed lung recruitability. They just said, you get it, you don't, you get it, you don't, you get it, you don't. Second point is, look at this. If you look at lung recruitability in ARDS, remember I told you lung protective ventilation, first step, optimize the PEEP, or wait, or do not do lung. If you do it early in ARDS, look how much potential, this is the percentage of the lung that can be recruitable you have. But if you wait 5 days, then you have late ARDS, and look how much less potential for recruitability there is. So this is late, and this is early. This is late copied to early, just so you see the difference. And this is the point. Whatever you want to do it early. Do it when you intubate your patient. Do it when you optimize. Do it immediately, then is your window to do it. If you wait for 5 days, you know, Friday night ventilation, we leave residents all weekend in the ICU, and they just make guided ventilation, then on Monday after 4 days, well, I'm not so sure that even the best experts can help. So now, of course, maybe some of you are still interested in doing lung recruitment. Maybe I can interest you a bit more. The point is, we know that we want to give lung recruitment, but only to those who are recruitable. And we don't want to do it to those who are not. This is the key point. So of course you ask me, how can we assess recruitability? And I give you 4 answers. 1, CT scan. Very nice for Professor Gattinoni, but very unpractical for all of us mere mortals. Because anybody of you use CT scan to do lung recruitment, so you take your patient to the CT scan, then you do lung recruitment there, then you optimize, then you take your patient back from the CT, right? Well, probably not. And then of course there's the lung ultrasound, which I really like, but there's one problem. For lung recruitment, also there's 2 more problems with lung ultrasound, but one has been addressed by my colleague in the previous lectures. It takes real experts, because you know everybody says they do it. In real life, only a few do it, and most of them who are doing it are not doing it very well. That's first point. But the second point is to go back to real life. If you want to assess lung recruitability in a lung, okay, how many points with lung ultrasound do you have to monitor at the same time? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, right? You need at least 3 points in the front, 3 points in the back, 2 sides. That means 12 ultrasound probes, 12 hands. I have only 2, maybe some of you have 12, and 12 monitors. Because when you're assessing, you need to monitor all 12 points at the same time, right? So maybe for after lung recruitment, I would agree, but for lung recruitment assessment, I don't think it's that feasible. EIT, I fully agree. Let's see what the studies show us, maybe in the future. We will see. There's still, you know, there's a big fuss about EIT, but real studies showing improvement based on EIT are lacking. Maybe we agree on this, right? And then, of course, what I offer is the PV tool. The PV tool, and this is why we do it every day, easy to perform, quick, takes only 40 seconds to analyze, and then I've made my decision on recruitability. Then I will make further decisions on whether to recruit or not. So let's go back to my patient. Remember, this is the patient. We perform a diagnostic low flow PV loop using the PV tool. So it's available. So PV tool, we go to PV tool. How to perform it? For diagnostics, I want the lung fully empty. This means I tell the machine, go down to 0 pressure, go up to 40 please, then go back to 0 with the slowest increase time possible, okay, to avoid resistance, okay, I only want compliance. And of course, T-pause means 0 seconds, I don't want any lung recruitment now, I just want to assess recruitability. So remember, not recruitable, no, don't recruit. Potential recruitable, let's evaluate. So if he's recruitable, then I'm gonna recruit. And it takes you only 40 seconds, plus a few more. These few more mean that once the machine starts to do this, it's going to wait 5 time constants for the lung to fully empty. This is very important because precision volume measurements need lung to be fully empty, okay? And then, how can I assess? When I get this curve, how do I know from this curve that my patient is recruitable? Well, there's a nice new study by Davide Chiumelo and Jean-Michel Arnaud, performed in severe ARDS, that compared this PV curve to the CT scan, which is still the golden standard. And they found that the hysteresis of a slow low flow PV loop expresses alveolar recruitability, okay? And this can be measured using something that is called normalized maximum distance. This is important, why? Because each one of us have different lung size, right? Okay? And the potential for recruitability has to be expressed by the potential to fully inflate. So the lung volume when are fully inflated, which we can reach, plus this hysteresis of the PV curve. And this ratio of maximum distance between inflation and deflation and the maximum volume achieved gives you the so-called normalized maximum distance ratio. And now this ratio can help you decide whether, if with a high ratio means 0.41 or over, theoretically, your patient is a recruiter, or you see it here, practically no new volume inside between inspiratory and expiratory limb of the PV curve, NMD 0.22, you have low potential for recruitment. This now means in 40 seconds maneuver, I have a clinical picture to decide whether I want to do lung recruitment or not, okay? So back to our patient. Now this is very nice. It's 5 p.m., okay? And look at my patient. We have difference between my maximum distance is 524 milliliters and the maximum volume achieved is 1093 milliliters. This gives you an NMD of, can somebody calculate quickly? Or maybe I just speed it up. It's 0.48. So would you do lung recruitment now in this patient? So how many of you would do lung recruitment? Please raise your hands. Oh, 1, 2, oh. You see all of those you didn't want to do lung recruitment before this lecture. Thank you very much. This is great. Yes, I will do lung recruitment. So we decided. Now, remember 2 options. First of all, somebody say, I don't do lung recruitment, I will just increase the PEEP. The problem is, and we know this from the Crotty study, that the opening pressures and the closing pressures for the same alveoli are not the same. This means, if you want to open alveoli, you need higher pressure than to keep it open. On the other hand, for you, this means if you apply PEEP, either it will be too low to open, or if it's too enough to open, it's unnecessary. This will be like that over distension because this alveoli can be opened at lower PEEP. This is why I apply transiently higher transpulmonary pressure. We always talk about transpulmonary pressure, and then go back to a new PEEP that will now be enough. This is, remember, look, 17 of PEEP, 90% of FiO2. Nothing happened. This is why not just increase the PEEP. Okay, so now you ask me, we agree there's at least 5-10 of you who want to do lung recruitment. Now you ask me how I do it. Very simply, I use the same maneuver. Just adapt it now to be a lung recruitment maneuver. Now I need 3 more things. I need a top pressure, at which I'm going to recruit. Now I no longer need to go from 0. I don't need the lung fully empty. I know I'm going to recruit, so I can start from my PEEP. What I need now is the new PEEP. Remember, no point in lung recruitment unless accompanied by some new or some level of PEEP that's going to keep these alveoli open. This can theoretically be, this patient was, this patient was at 17, so it can theoretically be 17 or 15 or 25 again. It's just a point that I need to set new PEEP. Increased time can now be a little bit quicker because I'm no longer worried about resistance, but theoretically I always keep it at 2, but you can go to 5, doesn't matter. T-pause. This means how long my maneuver should last to be a lung recruitment maneuver. This means for this patient, I will start from PEEP, go to 40, wait there 10 seconds, and then go back to the new PEEP, okay? And this will take you only 20 to 40 additional seconds. Remember, brief lung recruitment, okay? And now you ask yourself, you see this is red, how can I decide on these 3 things, okay? First of all, what about pressure? We know that in severe ARDS, lung recruitment pressure varies from 30 to 60, but for safety reasons, I would never go for the initial maneuver over 40. Then, if I think there's potential to go more, or as the colleague has shown, I have a transpulmonary catheter inside, which means I know that I'm very much in minus before I do, then I can use also higher pressures. What about transpulmonary pressure? You know that, and it has been shown, if you apply 30 centimeters of water for the same lung, it can be 25 in the lung, or it can be only 15, if 15 are needed to expand the chest wall. And also, why esophageal pressure is great for recruitment? Look here. The proposed threshold for the esophageal pressure recruitment is 20 centimeters of water of transpulmonary lung pressure. But this can be achieved in ARDS patients with 35 of airway pressure, but also with 45. And you don't know. And this is great to have an esophageal catheter inside. And also later you can watch, as you watch the PV curve airway pressure, you can also look at the lung PV curve. And you can see, for example, in this patient, we never reached 20 centimeters of water, right? This means I need to increase the airway pressure, okay? This is here. Okay, now we have two components, 10 seconds and the new PEEP, right? Why 10 seconds? Now this brings me back to the ARDS trial and why we know there's no point in doing long-run recruitments. 2011, look, 2011, the study by Jean-Michel are now showing that in the first 10 seconds, in recruitable patients, around 90% of the lung will recruit within 10 seconds. And hemodynamic instability comes after these 10 seconds. So theoretically, 10 seconds is a reasonable compromise with practically max lung recruitment versus no hemodynamic instability. So why would you do a lung recruitment maneuver for longer than 10 to 15 seconds? And this study has never been contested in the later trials. But still, 6 years after, they do it in a staircase maneuver. Disaster. Okay, and this brings me to $1 million question, how to set the PEEP after lung recruitment. And again, if you go to Congress, this is what it looks like. Everybody of us is looking for that PEEP, rarely we can find it. And the professors, they're arguing, I'm a high PEEP believer, no, I'm low PEEP. You see, one time they use low PEEP table, then they use high PEEP table, then it says, I use esophageal pressure. But in one study, compare it to low PEEP table, then in the other study, compare it to high PEEP table. Oh, P.S., the high PEEP table worked, because this is why in the low PEEP, in the first study, they had better results with esophageal pressure, because low PEEP was too low for severe ARDS. But we know that in ARDS in PEEP should be higher in moderate and severe. And the ATS guidelines still confirm that. But let's go back to guidelines. SCCAM says no. We cannot make a recommendation. And we changed this because no effect. And we changed this since 2017. And then again, you have this mean little guy from Croatia who goes and reads this guideline completely. And then he goes to the end of the guidelines and there is references. And you know which studies they used in 2017. The alveolar trial, the LOVES trial, and the EXPRESS trial, okay? And in 2023, they used these totally three new trials. Alveolar trial, the EXPRESS trial, and the LOVES trial. Meaning, they took the same three trials and they make one decision in 2017 and they make another decision in 2023. So either they did it wrong the first time or if they just took them 7 years to analyze three studies. I'm not sure. Anyhow, it's very confusing for me as a clinician. Of course, keep in mind there's a lot of things how you can set up the PEEP. Low inflection point, deflection point, PEEP to table, stress index, minimum PEEP, incremental PEEP, esophageal, very much I like it. But there's one point, and this is real life. I have to accept, and this is real life for all of you, also for me. As soon as there are this many ways to set something up, and none has been exclusively best one in the studies, that means that we are still looking for the best way on how to do it. So, if you ask my clinical approach with the PV curve, two things. Either, A, I have the esophageal pressure measurement, as my colleague said, then I would combine the PV curve with the esophageal pressure. I will show you how. Always target around 0 to +1. This is my philosophy. But then again, there's a very interesting topic we will see about how to set, is the same PEEP setting applicable for transpulmonary and expiratory PEEP setting in SPONT and in controlled ventilation, remains to be seen. But for real life, How many of you regularly place esophageal catheters? 1, 2, okay, that's it. This means you don't have it in real life. So me preaching you now means only you will be interested in using it later, but you need a weapon now, right? When you go tomorrow to your ICU. So how I do it, I take two things. First of all, classic approach is low inflection point on the PV curve and then find it. But keep in mind, is your PEEP a recruiting force or an anti-de-recruiting force? It's not a recruiting force. Remember, if it was a recruiting force, I could just set a PEEP, no longer recruitment. PEEP is an anti-de-recruiting force. So if it prevents de-recruitment, isn't it logical to use a deflation limb rather than inflation limb, okay? But remember, the problem with the deflection point on the PV curve, let me just give you a second back, sorry. So, okay, this is the deflection point. So these are inflection, or whatever. This one, sorry, this one. So you have low inflection point, upper inflection point, and the deflection point. The problem is recruitment occurs all along this line. And PEEP is a de-recruiting force, so I will look somewhere here. If I look at the deflection point, the problem is, remember, I am not setting plateau pressure. I'm setting the PEEP. So after PEEP, I still need to give tidal volume inside, right? And the problem here is that if I give tidal volume here, you see, with pressure, there is absolutely no tidal volume going in, only the pressure is rising, okay? So this means that the deflection point is too high to be the set of PEEP, right? Okay? So what I do, I go from this point down a couple of centimeters of water, usually for the half of tidal volume, okay, half. That's just my clinical experience. And then afterwards, after this, I use a decremental PEEP trial guided by SpO2 using Intelligence protocol of, remember, high PEEP, low FiO2 table. So I find higher PEEP and then just let the machine go down, first with the FiO2 and then if it can, a little bit more with the PEEP. This is how I do it clinically. Stress index, whatever, I rarely use. Okay, so where does this take us now in ARDS? Do we use low tidal volume for all? Do we use diving pressure, whatever, open lung approach? Or, remember this approach, close the lung and keep them closed. The point is, what I want to tell you, is this evidence-based medicine in the guidelines, or we still want to use a sound clinical judgment instead? Okay? If I tell all these animals, please climb the tree, is this a fair fight? And this is how it looks like if you tell all the patients they get 5 of PEEP, 10 of PEEP, 12 of PEEP, or whatever. One size does not fit all, and I think this is the point. And then, of course, you say, oh, I don't believe to this guy in Croatia, he's talking stupid, don't know what. I have 10 golden rules. Oh, you look for in Google, 10 golden rules for individual mechanical ventilation in ARDS, great. And there's some very big names written. So they say high versus low PEEP means 12 centimeters of water. So is there anyone in the room who is at least 185, 190 centimeters tall? No? Okay, sorry. So stand up, because I'm 168. So is 12 of PEEP the same for me with 30 kilo obese, or 195 centimeters tall guy with no belly? Of course not. 12 PEEP means nothing. It's transpulmonary pressure you heard from the colleague. This is highly individual. This means that the difference between high and low PEEP 12 centimeters of water is totally stupid. And then, of course, never use PEEP over 15, but based on the ART trial. If I have to say ART trial one more time, I will just collapse, because there's no point in using this trial for anything. And then, of course, recruitment orders not recommended regardless of recruitability assessment, again based on the ART trial. Well, I'm so sorry, but I personally cannot take this as anything relevant in my clinical perspective. And this is why I don't like guidelines in ARDS. Exactly, they're more what you call guidelines than actual rules. So individualization is the key, yes. And if you look at the fantastic paper, very great. So now all these guys, they write guidelines. But then there's this Ivan Goliger who says, okay guys, now I'm going to gather you around, 31 experts from all around the world, and I'm going to ask you, what are the most important things in ARDS? So do we agree? And then you have to give a note from 1 to 9. What is important in your treatment of ARDS? Is it PEEP optimization, low tidal volume, driving, pressure, whatever? And you know the only one, and there's like, I don't know, 20 questions. And you know the only one thing they all agreed on is this. Oh, sorry. There is no single universally applicable algorithm, one size fits all for optimal mechanical ventilation. Okay? And ventilator settings should be tailored to individual patient's characteristics on the basis of the clinician's measurement of the most pressing risk to the patient in any given situation. Integrating the best available clinical experimental evidence with a sound mechanistic evaluation of the patient's condition. And this is the only thing that all 31 agreed, with a range of only 7 to 9, meaning they only agree on this. So now you can take your guidelines, walk out, there's a trash can, and just throw them in the trash. And then, of course, there's the study proving it in 2019 by Jean-Michel Constantin, where they say, okay, we will personalize patients according to lung morphology. So usually those with focal morphology are non-recruiters, those with diffuse ARDS, they are recruiters. So in those diffuse, we will give lung recruitment, and in focal lung morphology we will not. And the problem is, they get absolutely no difference. And then these guys from SECAM guidelines, they're, yes, so finally. The problem is that these guys are very clever, and they say, oh, something is wrong, this cannot be. So we take another look at our patients and find that we totally misclassified a big number of patients. So when they reclassify, this is where the people from SECAM guidelines start sweating. They see that there is that the biggest problem is that if you misclassify your patient, this means if you apply lung recruitment to non-recruiters or don't apply to those who are recruiters, you get a very low survival rate compared to those when you apply the correct setting for the correct individualized patient. And this is where it gets tricky. Oh, I have to speed up, sorry. So, and this brings me to another important mission. What about heart-lung interactions? This has been mentioned. Remember, cardiac output. Only one good thing, mechanical ventilation has minimal influence on contractility, but has a very high influence on right ventricular, left ventricular preload, as well as right and left ventricular afterload. And there is something that's called ventilator-induced right ventricular dysfunction. And everybody who says don't use high PEEP in ARDS, you're killing the right heart, right? And this is like all papers. The problem is, yes, I fully agree that if you induce afterload, increase pulmonary vascular resistance. Remember my term pulmonary vascular resistance was on this slide before. ARDS has hypoxia, pulmonary vasoconstriction, microthrombosis, etc. And yes, we have core pulmonary 20 to 25% ARDS patients. And yes, one of the big risk factors is high ventilation pressures. That doesn't mean necessarily high PEEP. That theoretically means high PEEP over transpulmonary pressure 0 for a certain alveoli. Okay? And again, remember del sorbo, in overstretched alveoli as well as in closed ones, you have increased pulmonary vascular resistance. So what you're going to do for hemodynamics? Well, you have to remember physiology. Why do you have this increased resistance in both closed and the open alveoli, in overstretched alveoli? Because there are two types of vessels in the lung. There's the corner vessels and the septal vessels. And the ones have highest pulmonary vascular resistance when the lung is fully collapsed. The others have the highest resistance when the lung is fully open. But the lowest combined pulmonary vascular resistance, meaning the lowest work against the right heart has to do, right, is at the point of functional residual capacity, which I lose with de-recruitment, in ARDS, supine, and sedation. So if I can reconstitute the FRC with a good lung recruitment maneuver, I will lower pulmonary vascular resistance and paradoxically, even with higher PEEP, unload the work of the right heart. And this is like that. So how to optimize your mechanical ventilation for right heart? You have to think about it. You have ultrasound, optimize PEEP, remember point 1, optimize lung recruitment, then use low plateau pressures and use prompt positioning. So we did a lung recruitment using the PV tool, okay? here, and you can see whether this was effective if you measure this volume, and if it's over 2 ml per kilo, this is the new volume during lung recruitment inside the lung. If it's over 2 per kilo of ideal body weight, then lung recruitment maneuver was effective. Of course, there are other methods how you can assess. Some are good, some are not. We can debate this later. And let's look at our patient, because I don't care about papers, I like patients. Same day, 9 p.m. Remember, same PEEP. But high pressures to open, same PEEP to keep them open. 66% of FiO2, 93% of SATs. Satisfied? Maybe not, you don't know hemodynamics. Let's look at the hemodynamics. Cardiac output before lung recruitment, 5.4. Immediately after lung recruitment, 6. How is it possible? I now give very high pressure inside the lung and I have an increase in the cardiac output. Just because with the good lung recruitment, I recruited the lung, lowered pulmonary vascular resistance, and this is how I unloaded the right heart, and the left heart can only be as good as the right heart. And day 12, let's go to SPONT. See, SPONT breathing at high PEEP, no problem, 39%, 94. Then a couple of days later, I go to SBT, 5 PEEP, 30%, 25, like I've shown you in the first lecture. And the patient was weaned off. She got chemo, of course, and the resistance weaned off the ventilator, extubated, high flow, 60 liters, 35. 3 days later, she was discharged to the ward. Unfortunately for the patient, afterwards, second, third, fourth chemo, she got sepsis and unfortunately died, but this was a progression of the malignant disease and not what we were treating. So I think we still don't know what we are doing. But instead of relying on guidelines that target just the middle group of patients, I think we need a little more knowledge, meaning measurement, including what I showed you and what the colleague showed you with the esophageal pressure to light our way. Thank you very much.